Okay, so let us start with the part 2. In this we'll see the management. Now first one is the enamel infraction. What is infraction? There is a small crack in the enamel, that is what known as enamel infraction. Clinical findings, visual examination, if you want to do, you can use dyes like methylene blue. Tooth is not tender on percussion. If tender on percussion, check for the luxation or root fracture. What are the radiographic findings? No radiographic abnormality is usually seen. If periapical view radiograph is used, additional radiograph if signs and symptoms are present. What are the treatment options? Etching and sealing with the resin to prevent the discoloration of the infracted line. Okay. Clinical again I am doing enamel infraction. Clinical findings, if you want to see, visual examination can be done with the dyes like methylene blue. If usually tooth is not tender on percussion, if it is present, check for the luxation or root fracture injuries. Radiographic findings, usually no radiographic abnormality. Periapical view radiograph is used and more radiographs are needed if signs and symptoms present. Treatment, etching and sealing with the resin to prevent the discoloration of the infracted line. Now next is the enamel fracture. Clinical finding, visual signs you will see, loss of enamel without the dentine exposure, no tender on percussion, pulp sensitivity test is recommended. We'll come on to the sensitivity test later on. Now coming on to the radiographic findings. Visible enamel loss can be seen. Radiographs of lips, cheeks to find out any root fragment or foreign material if present. Treatment. Smoothing of the margins to prevent lacerations of the soft tissue. If in extensive cases, recountering of the roughened margins are needed with aesthetic composite restoration. Fracture segment is available, reposition it and bond the tooth. Okay. Once again, treatment for enamel fractures, smoothing or the using the polishing burr the margins to prevent laceration of the soft tissue. In cases of extensive cases, recountering of the rough end margins using aesthetic composite restoration. Fracture segment is available, reposition and bond to the is repositioned and it is bonded to the tooth. Suppose what is this, you might be thinking, fracture segment. If the patient comes along with the broken fragment of the tooth, then you can reposition it and then bond it to the tooth. Now coming on to the enamel and dentine fracture. Crown fracture without the pulpal exposure. Objectives is to eliminate the discomfort of the patient, to preserve the vitality of the pulp and restore restoration of the fracture of the crown. Clinical finding, no TOP. If pulp tests are positive, then that means there is no necrosis. Okay, radiograph enamel and dentine loss can be visible in the radiograph. Treatment, if remaining 2 mm of dentine thickness is sufficient for pulpal protection. Okay, so if 2 mm the dentine thickness is there, that means you can give a composite which is preferred, reapproximation and bonding of the segments with dentine bonding agent and composite. Okay, you can give indirect veneering can be done, or polycarbonate veneers can be used. Okay, tooth is periodically checked for the vitality using the pulp tester. If more current is needed, that means to elicit the response, that means the tooth is poor prognosis, might be going for necrosis. Now coming on to the third type, that is enamel dentine and pulp fracture. Crown fracture with pulpal exposure. Clinical findings, the tooth is, if it is not tender on percussion, that means no infection is present. In radiograph, you can see the loss of tooth structure is visible. 4 kind of treatment can be done: direct pulp capping, pulpotomy, apexification, pulpectomy, and the new one is the regenerative techniques. So it depends upon DPC and pulpotomy, depends how long the injury time has been passed through the duration of the injury. Next is the apexification, if open apex, non-vital teeth, pulpectomy, endodontic treatment. Okay, it is said that mechanical exposure of pulp due to trauma is that is freshly exposed has better prognosis than the carious exposure. So coming on to the direct pulp capping. It is a pinpoint exposure, that is 1 mm or less than 1 mm. For direct pulp capping and all these definition, you have to go to my older video of direct pulp capping definition. There I have explained. So when do we do that? When there is a pinpoint exposure, that is 1 mm or less than 1 mm. and the patient should report between 24 hours duration. Indication: small carious mechanical pulp exposure. The pulp should be vital. My objectives are to maintain the vitality. No post-op signs of sensitivity or pain or swelling should be present. No radiographic evidence of internal root or external root resorption should be present. Tooth with immature apex should show continued root development, that is apexogenesis. Now there is a supporting literature by A. Rahmani et al. 2021 in the Journal of American Dental Association. They concluded that direct pulp capping with MTA has proven to be given an effective outcome for managing the this fracture. Now next can be management can be partial pulpotomy, that is Schweck's pulpotomy can also be done. It is done in inflamed pulp tissue beneath the exposure. It may be 4 mm or less, is removed to a depth of 1 to 3 mm to reach the deeper healthy tissue. Literature indicates Schweck's pulpotomy may be completed up to 9 days after the exposure, but there is no evidence on outcome with longer waiting period. This was concluded by Bimstein et al. 2016 on Dental Traumatology Journal. Then after removing 1 to 3 mm, hemorrhage control should be done using sodium hypochlorite or the chlorhexidine. The site should be covered by MTA or calcium hydroxide. MTA at least 1.5 mm thick should be used to cover the exposure site, followed by the light cure RMGIC, which prevents micro leakage. This using of micro leakage RMGIC prevent micro leakage RMGIC was shown in the article Buckland et al. On new endodontic procedure using MTA for teeth with traumatic injuries 2007. Okay, indications of Schweck's pulpotomy: vital traumatically exposed tooth, young permanent teeth. Objective: remaining pulp should be vital, no adverse outcome, and continued root development should be seen. Now next is the complete pulpotomy. It is the removal of the entire coronal pulp followed by the placement of a suitable medicament in the pulp chamber and restoration of the teeth. MTA and tricalcium silicate exhibits a superior long-term seal and reparative dentine formation. This was concluded in the study by Winterspoon et al. 2008. MTA tricalcium silicate superior long-term seal and reparative dentine formation, Winterspoon et al. 2008. Indication: full pulpotomy is indicated in immature exposed pulp and allows the continued root development. Objectives: vitality, continued root development. Now next is the apexification. It is to induce the root end closure using a biocompatible agent. Calcium hydroxide is placed in the canals 2 weeks to 1 month. 2 weeks to 1 month to disinfect the canals. Then root end closure using MTA is done. When cannot achieve using MTA, absorbable collagen wound dressing may be used, which was concluded by Patino et al. Collagen as implantable material in medicine and dentistry 2002. Guttapercha is used to fill the remaining canal space. If canals are thin, space can be filled using MT or composite resin instead of guttapercha to strengthen the root against the fracture. Indications: non-vital young permanent tooth. Objective: tooth should continue to erupt, allow the alveolus to grow along with the adjacent tooth. Now last is the regenerative endodontic procedure can be done. It is a biologically based procedure. It replaces the physiologically damaged tooth structure, including dentine root as well as the pulp dentine complex. It eliminates the goal is to eliminate the clinical symptoms, resolution of apical periodontitis, thickening of the canal walls, or continued root development. What is the difference between the root canal treatment and regenerative endodontics? In disinfection of the root canal space in the former therapy, that is root canal therapy is filled with the in the regenerative therapy is filled with host's own vital tissue, and canal space in the root canal therapy is filled with biocompatible foreign material. I hope it is clear. In regenerative endodontics we are using host's own vital tissue, and for a root canal biocompatible foreign material. Indication: non-vital permanent teeth, young tooth. increase in the width of root walls, increase in the root length, no post-op symptoms. Tooth alveolus should continue to erupt along with the adjacent tooth. I will make a separate video on regenerative endodontic as it is a big procedure. So now we will continue with our the management of trauma. Okay. Now next is the crown root plus cementum fracture. You can see here pulp is not involved, crown root and cementum fracture, and oblique line fracture. It begins at the incisal to the marginal gingiva, extends beyond the gingival crevice. Fracture segment are held by PDL. Tooth is TOP positive will be seen. Coronal fragment is mobile. Sensibility test is positive for the apical fragment. Now radiograph you can see it is recommended to take periapical, occlusal and eccentric exposure to detect the fracture line of the root. Again I am repeating, periapical, occlusal and eccentric exposures to detect the fracture line of the root. You have to see different angulations will be needed to see and to evaluate the exact fracture location and the line. Now what will be the treatment? First, when you have localized, if the localization of the fracture line, CBCT is the best choice. Emergency treatment is temporary stabilization of the loose segment to the adjacent teeth. Okay, temporary stabilization. Definitive treatment is if it is it's a superficial fracture, removed and removal or reattachment of the fracture segment. Removal is indicated in superficial or chisel fracture. Okay. Subgingival extension is converted into supragingival fracture by gingivectomy or osteectomy.